The following podcast is part of a certified educational activity titled A Recap of Therapeutic Advances in HER2-Positive, HER2-Low, and HER2-Ultralow Breast Cancer, Navigating the Latest Evidence and Maximizing Clinical Impact. Access the entire activity and complete the post-test at peerview.com/TQX860. Downloadable slides are also available.
Welcome, everyone, to this PeerView activity, navigating the latest evidence and maximizing clinical impact of novel antibody-drug conjugates against HER2 and TROP2. So we'll walk you through the latest therapeutic advances in this past year in HER2-positive, HER2-low, HER2-ultralow breast cancers, and also cover the role of TROP2 ADCs. The goals for today's discussion are to equip you with the knowledge about the latest evidence supporting the use of ADCs and other novel therapies in HER2-positive, HER2-low, HER2-ultralow breast cancer, and enhance your skills in integrating these antibody-drug conjugates that are already approved and other novel therapies into individualized treatment plans for appropriately selected patients with HER2-positive, HER2-low, or HER2-ultralow breast cancer. Joining me today is Dr. Giuseppe Curigliano, who is a professor of medical oncology at the Department of Oncology and Hemato-Oncology at the University of Milano. He's also the director of the Division of Early Drug Development for Innovative Therapies at the European Institute of Oncology in Milan. And I'm the Patricia and James Kane Chair for Junior Faculty and Associate Attending in the Breast Medicine and Early Drug Development Service, Section Head for our Endocrine Therapy Research Program, and a Clinical Director for our Early Drug Development Service at the Memorial Sloan Kettering Cancer Center in New York. So welcome. So let's talk about the past, present, and future of HER2 expression and classification of breast cancer. We really started with defining HER2 as a binary way of treating patients, meaning we would treat patients with HER2-positive breast cancers with anti-HER2 therapies, and there was no role for HER2 therapies for HER2-negative tumors. But we've really come a long way. We now have a new clinical entity, what we call as HER2-Low, which is really IHC1+ or IHC2+, that is not FISH amplified. And we'll talk a little bit more about that during this discussion. And since then, when we thought about HER2-low, HER2-positive, and HER2-0 as the way of defining HER2-expressing tumors, we have now come to a conclusion that even HER2-0 tumors can have tumors that express some HER2, which we now call as HER2-Ultralow. And this is really, really important because our currently available novel antibody-drug conjugates can have activity not only for HER2-positive tumors, but also have activity in HER2-low tumors. And now we've seen some activity and some results that we'll talk about today, even for HER2-ultralow tumors. So really a long way of realizing that this is a continuous spectrum of HER2-low expression. So let's start with where we began this journey of antibody-drug conjugates in breast cancer, which is in HER2-positive metastatic breast cancer. And the first prototype antibody-drug conjugate that really changed the field in breast cancer with the introduction of antibody-drug conjugates was trastuzumab emtansine, or T-DM1. This was the first antibody-drug conjugate, as we said, that was approved. This ADC has a non-cleavable linker. It was active in trastuzumab-resistant HER2-positive metastatic breast cancer. The payload for this antibody-drug conjugate is an antimicrotubular payload, which is emtansine. And really what is shown here on this slide is how we have been able to utilize this antibody-drug conjugate in clinic with 3 clinical trials that have led to positive results, initially with the second-line Amelia study in the metastatic setting. We have data from the Theresa trial beyond the second-line setting. And then now we have the Catherine data, which has changed our standard of care practice of utilizing this drug even for early-stage HER2-positive breast cancer. So talking about Amelia, this was the phase 2 trial with HER2-positive cancers. These were locally advanced or metastatic tumors that had previously been treated with trastuzumab-based therapy, nearly 1,000 patients that were randomized to T-DM1 versus the standard of care then, which was lapatinib and capecitabine. And we saw not only a statistically significant improvement in progression-free survival, but also an improvement which was statistically significant in overall survival, which led to reutilizing TDM1 as a choice of second-line therapy replacing lapatinib and capecitabine in 2012. Since then, we've also been able to utilize TDM1 in early stage HER2-positive breast cancer, specifically with the help of the Catherine trial design, wherein patients who were treated in the early stage setting with neoadjuvant anti-HER2 based therapy, and despite that, if they had residual disease, they were randomized to receiving TDM1 versus trastuzumab. And in that setting, we were able to show initially an improvement in invasive disease-free survival, but with longer follow-up up until 7 years, we've now also been able to show an absolute overall survival benefit. In fact, the delta of benefit is 5% at 7 years, as shown here on this slide. So really a remarkable progress for our patients with HER2-positive breast cancer in the early stage setting as well with this prototype antibody-drug conjugate. Now, while we were very appreciative of this antibody-drug conjugate and have been able to change standard of care in the metastatic and early stage settings, we now have newer antibody-drug conjugates such as trastuzumab deruxtecan, which are distinct from TDM1 in that the payload is a topoisomerase 1 inhibitor, a very potent payload that traditionally we don't treat our breast cancer patients with. So they've not been necessarily treated with this payload. The drug-to-antibody ratio is higher with T-DXd in the order of 8:1 compared to 3.5:1 with TDM1, which means we're delivering 8 molecules of the payload for every antibody. Instead of a non-cleavable linker in TDM1, we have a cleavable linker with T-DXd, and this really allows us, with membrane permeability, what we define as a bystander effect. And this is why we have seen activity with HER2-low and ultra-low tumors that we will hear a lot more about from Dr. Grugliano as well. So how did T-DXd fare for patients with HER2-positive metastatic breast cancer, and where are we now with this agent? The DESTINY-Breast03 trial was really designed to understand if T-DXd would be superior to our currently available ADC back then, which was TDM1. So these were patients previously treated with trastuzumab and a taxane in an advanced or metastatic setting. Stable treated brain metastases patients were also permitted on the study. Patients were randomized to T-DXd, delivered at 5.4 milligrams per kilogram every 3 weeks versus TDM1 at standard of care of 3.6 milligram per kilogram every 3 weeks for a primary endpoint of blinded independent central review and a key secondary endpoint of overall survival. And shown here are the results from the DESTINY-Breast03 trial. On your left are the Kaplan-Meier curves for progression-free survival, your primary endpoint, where we see more than 4 times improvement in median progression-free survival with T-DXd, improvement from 7.2 months in the TDM1 arm to 29 months with T-DXd, a hazard ratio of 0.3, which is highly statistically significant. On your right are the Kaplan-Meier curves for overall survival. Again, we've seen an improvement, a 10-month improvement in the delta of benefit for overall survival, improvement from 43 months nearly to 53 months in the T-DXd arm, hazard ratio of 0.73. And needless to say, this is why we have replaced T-DXd with TDM1 as a standard of care for our patients in the second line and beyond setting based on the DESTINY-Breast03 trial results. Now, at the past annual San Antonio meeting in December of 24, we saw exploratory biomarker analyses comparing T-DXd with TDM1 efficacy from this DESTINY-Breast03 trial. Essentially, we tried to look at if there were any genomic alterations that could explain if patients were more likely to benefit from T-DXd compared to TDM1 or were more likely to be resistant. And what we learned was that T-DXd maintained superior activity compared to TDM1 regardless of presence of predefined detectable baseline genomic alterations relevant to metastatic breast cancer, which included PIK3CA mutations, HRD, BRCA1 or 2 mutations, or even P53 mutations. What was interesting and something that we have seen with other data sets as well was that emergence of TOP1 mutations after T-DXd treatment did represent a potential mechanism of resistance in a limited number of patients from DESTINY-Breast03 trial, which makes sense given that the payload here is a topoisomerase 1 inhibitor. Now, where else can we utilize T-DXd, and how are we thinking about our treatment paradigm? Now, traditionally, when we replace T-DXd for patients with HER2-positive metastatic disease from utilizing TDM1, we were using this agent mostly for patients with stable brain metastases and then have systemic disease progression, because we have other data sets that we'll talk about, such as the HER2 climb regimen, which we definitely thought about preferring, especially if patients only were dealing with active brain metastases. But then we saw the results from the Destiny Breast 12 study, which might suggest that maybe we can utilize this drug, this antibody drug conjugate, even in patients with brain metastases, including active brain metastases. So let's walk through these data together. So these are, again, patients with documented HER2-positive advanced or metastatic disease. These were tucatinib naive patients with no more than 2 prior lines of therapy in the metastatic setting. Patients with leptomeningeal disease were not permitted on this study. There were 2 cohorts. These were not randomized cohorts. These were not meant for comparison between each other, but 2 cohorts, one with baseline brain metastases patients and the second without baseline metastases. And the primary endpoint was progression-free survival for these patients. The primary endpoint for the no baseline brain metastases was overall response rate. All patients received T-DXd at standard of care dosing. And these are the results for the waterfall plot in patients with measurable CNS disease at baseline. This was a post-hoc analysis. And as evident in this waterfall plot, you can see that T-DXd showed substantial CNS responses in the overall brain metastases population, including patients with stable and active brain metastases. I must point out that this cohort is the largest cohort to date to test the activity of T-DXd in patients with brain metastases, with nearly 250 patients. And as you can see, almost all cohorts, whether it was active brain metastases or stable brain metastases, had an overall response rate in the range of 60 to 80%. When we looked at PFS in patients with brain metastases, again, T-DXd showed consistent 12-month PFS in patients with both stable and active brain metastases. And the intracranial and extracranial overall response rates were also comparable. T-DXd also showed consistent 12-month overall survival benefit in patients with and without brain metastases, as shown here on the Kaplan-Meier curves. So really what we learned from this Destiny Breast 12 study, that perhaps when we were thinking that maybe we don't have enough data to justify T-DXd in active brain metastases, Destiny Breast 12 suggested that that's not the case, that in this big cohort of patients with brain metastases, we saw very good activity for this T-DXd agent in patients with brain metastases, including patients with active brain metastases. And this really does have impact of our treatment paradigm for our patients in clinic in the second-line setting, including in patients that have active brain metastases as a treatment choice. We also saw some additional analyses based on health quality of life outcomes and neurological function that were presented at the annual San Antonio meeting from this Destiny Breast 12 study. And really what we learned, to summarize the results from this analysis, is that the estimated deterioration-free rates at 12 months were above 50% for cognitive, emotional, physical, and social functioning. And even the pain scores, regardless of the presence or absence of stable or active baseline brain metastases, really reassuring us that this goes in line with the efficacy and also confirms that there is no quality of life concern with T-DXd in this patient population. Majority of the patients had neurological stability at baseline, which was maintained throughout the treatment in 55% of the patients with baseline brain metastases cohort and approximately 73% in those without baseline brain metastases. Also in the baseline brain metastases cohort, mean severity in the last 24-hour scores for the majority of brain tumor-specific symptom items were 10 patients on a 0 to 10 scale, where 0 was not present and 10 was as bad as you can imagine. So really, again, reassuring that this is efficacious, was safe, and maintains quality of life. So where do we move forward from here? So currently, as we said, based on the Destiny Breast 03 and now the Destiny Breast 12, that T-DXd has become a very attractive and preferred antibody drug conjugate in the second-line metastatic setting, should we be considering this agent upfront in the first-line metastatic settings? And we have to stay tuned for results from these ongoing trials, with the exception of the PATINA trial that was just reported out and I'll talk about. So we have Destiny Breast 09 study, which is evaluating T-DXd in the first-line metastatic setting. This trial is also evaluating the combination of not only T-DXd as monotherapy against the Cleopatra regimen of THP, but also evaluating the combination of T-DXd plus pertuzumab. So we'll see if this trial will make a difference in how we think about utilizing this drug even in the first-line metastatic setting. Demeter is an interesting study, which is in a way complementary. It's not a registrational study, it's not a phase 3 trial, but I think it's a complementary data set that we will have results from, because it is evaluating the question of, should we continue T-DXd indefinitely in the first-line metastatic setting? Or should we be doing what we do in the Cleopatra regimen, where we give patients induction-based therapy and then we have maintenance therapy? So Demeter will look at T-DXd for 6 cycles, followed by maintenance Phesgo subcutaneous-based dual anti-HER2 therapy with trastuzumab-pertuzumab combination until end of treatment. HER2-CLIMB-05 is evaluating a question of seeing if we should use tucatinib, a TKI, as maintenance after patients have induction with a taxane HP-based regimen in the first-line metastatic setting. So various different approaches to see if we should be utilizing T-DXd first, or we should be looking at THP followed by tucatinib HP in the first-line metastatic setting. And at San Antonio, what we heard results from as a late-breaking abstract from Dr. Otto Metzger was from the phase 3 PATINA trial, which was asking the question specifically for our triple-positive breast cancer patients with ER-positive, HER2-positive breast cancer who have completed their induction therapy with the Cleopatra-like regimen, were then randomized to getting endocrine therapy with anti-HER2 therapy, or with an intervention of adding palbociclib, a CDK4/6 inhibitor, to this endocrine therapy plus anti-HER2 therapy. Now, as a reminder, in the Cleopatra regimen, this triple-positive patients in the maintenance phase were not allowed to get any endocrine therapy. But in this study, patients were allowed to get endocrine therapy, which is reflective of what we do in practice. And we were just asking the question, if we add a CDK4/6 inhibitor therapy, what would happen? And surely enough, the results were very, very appealing and have real implications of impacting our standard of care practice for this group of patients. There was an improvement in the control arm where we saw the median PFS of 29 months, unprecedented results for the control arm of endocrine therapy plus anti-HER2 therapy in the maintenance phase, to 44 months with the addition of palbociclib and continuing the anti-HER2 therapy with endocrine therapy. So certainly we have begun to see the role of maintenance-based regimens that can be modified. What about later line therapies for HER2-positive metastatic setting? We do have results for niratinib and capecitabine from the phase 3 NALA trial. Again, niratinib capecitabine was compared to lapatinib and capecitabine, which was the standard of care then. And here we saw, with a slightly better TKI, a pan-HER TKI, which is niratinib, we saw an improvement in both PFS and numerical improvement in OS. However, the improvement in PFS was rather modest. The delta of improvement was 2.2 months. It was statistically significant, but we challenged with whether it was really clinically meaningful. The overall survival benefit, while we saw a numerical gain, this was not statistically significant in the NALA trial with niratinib and capecitabine. As expected, there were fewer interventions for CNS disease occurrence with niratinib plus capecitabine compared to lapatinib plus capecitabine in this study, in this analysis, 23% compared to 29%, which was interesting. Also, what has changed our practice for some patients has been the HER2-CLIMB regimen. This study was for HER2-positive patients who've had prior treatment with trastuzumab, pertuzumab, and T-DM1, so really our contemporary patient population, who also, and this was the very first study that also allowed patients with brain metastases at baseline, both stable brain metastases, so those that were treated and were stable, or newly diagnosed, which were untreated brain metastases, or prior treated brain metastases with some progression, as long as they don't require any local interventions, were permitted on this trial. So really unprecedented effort to try and evaluate this patient population in HER2-positive disease. So the author should be recommended for this. These patients were then randomized 2:1 to the triplet of tucatinib, trastuzumab, and capecitabine versus placebo, trastuzumab, and capecitabine for a primary endpoint of progression-free survival. Of note, the patients with CNS metastases nearly comprised of 48% of the enrolled patient population. Shown here are the results from this. On your left are the progression-free survival from the primary endpoint, an improvement from 4.9 months to 7.6 months with the addition of tucatinib. Also seen was an overall survival benefit and improvement from 19 months to nearly 25 months, really impacted a standard of care and allowing us to utilize the HER2-CLIMB-based regimen specifically for patients that are appropriate for this regimen, including those with brain metastases, both stable and active, in the second line and beyond setting. We do have updated overall survival data now available from the HER2-CLIMB regimen in patients with active brain metastases. And as you can see, these are impressive overall survival benefit with tucatinib was improved, which was 9.1 months longer in the tucatinib arm compared to the control arm in all patients with brain metastases. When we break this down by patients with active brain metastases, it was 9.6 months longer than the control arm. For patients with stable brain metastases, median overall survival was 5 months longer in the tucatinib arm. So really a great option for patients in this metastatic setting, including those with active brain metastases with HER2-CLIMB regimen. We also then tried to ask the question, what if we were to combine an ADC with tucatinib? And which was the idea behind the HER2-CLIMB-02 trial, a randomized double-blind phase 3 trial that really evaluated patients, including those with brain metastases, to get randomized to tucatinib plus T-DM1 versus T-DM1 plus placebo. And we did see an improvement in progression-free survival here, which was statistically significant. However, it was rather modest and did have increased toxicity with this combination. We saw that the median PFS was 7.4 months, and with the addition of tucatinib to T-DM1, it improved to 9.5 months with a hazard ratio of 0.76. So while statistically significant, it was rather modest and certainly had more toxicities with the combination, which has not necessarily impacted our practice currently for our patients. We've seen overall survival data from here as well. This was a median follow-up of 24 months with about 53% pre-specified events. However, this interim overall survival results did not meet the pre-specified crossing boundary of p less than equal to 0.0041. We have the HER2-CLIMB-02 results as well for PFS in patients with brain metastases. Again, we saw an improvement from 5.7 to 7.8 months with the combination of T-DM1 plus tucatinib. Hazard ratio is 0.64. So good result. I think it's just challenging with the toxicity. So maybe before we move on to HER2-low and ultra-low metastatic breast cancer, maybe Dr. Corigliano, you had any thoughts about how you think about your patients with HER2-positive metastatic breast cancer, and how do you think about the HER2-CLIMB regimen, the data from the Destiny Breast 12, and how do you think about utilizing T-DXd, especially in patients with brain metastases? If you could comment on that.
Thank you. This is really an important question. A person, I believe that the data of Destiny 12 are convincing. So personally, I believe that if you have an active brain mass, looking also at the overall survival benefit of trastuzumab deruxtecan, I would consider as a first option trastuzumab deruxtecan rather than tucatinib, trastuzumab and capecitabine. But I would like also to add another concept. Overall response rate in active brain mets in the Destiny 12 was close to 80%. So I mean, if you have an asymptomatic active brain met that does not need to start radiation therapy as soon as possible, you can start trastuzumab deruxtecan and you can delay the use of radiation therapy. You know, in Europe, actually, T-DXd is approved in the second line setting And we have many patients like this with asymptomatic small brain mets. So personally, I believe we can really delay radiation therapy in this patient population, and we can start trastuzumab deruxtecan. So I would reserve in a majority of patients tucatinib, trastuzumab, and capecitabine in later lines. You may complain that you don't have evidence from a prospective randomized trial. I completely agree. But you have also to consider that tucatinib, trastuzumab, and capecitabine was completed in the post-T-DM1 setting. We don't have so many data after trastuzumab deruxtecan on tucatinib, trastuzumab, and capecitabine. I have another question for you. Looking at the data of the PATINA trial, do you really believe when the Destiny 9 data would be available, we should continue for 2 or 3 years with trastuzumab deruxtecan, or maybe we can stop after 6, 8 cycles after a complete response, and at least in HR-positive disease we can maintain it? Because I was impressed by 44 months of median progression-free survival. What do you think about this?
Yeah, no, I think it's such a fantastic question. I think we all were very, very pleasantly, happily surprised to see those results. I think the very first reaction was, why is the control arm doing so well? We're not used to seeing the control arm doing 29 months in the first line setting with this. But I think it was, a combination of that. We saw that there was patients who had already finished their induction-based therapy, and then we're teasing them out to see how they can get endocrine-based therapy, which the Cleopatra patients were not allowed to get. So we really did not have that data necessarily from there. So the control arm did well, but was very impressive was that with the CDK4/6 inhibitor, it has now improved to 44 months. So I completely agree with you. This really challenges the question, do we want to just keep continuing? Because we don't do that with the Cleopatra regimen. We certainly did not do that with the Patina and do have very impactful results. To me, I think I would love to see what the data from the Destiny Breast 09 study shows. What was really striking to me from the Destiny Breast 03 was that the complete response rate was 21%. And that I thought was very impressive. Does utilizing this agent push that complete response rate even further? So dare I say, are we providing a potential cure to a larger proportion of patients by using this very, very active drug upfront? And should that be something that we should consider? What will that combination of T-DXd plus pertuzumab show? Will that have a different impact than T-DXd alone? Certainly, quality of life and patient outcomes are going to be very, very important. Do patients tolerate this for such a long time, or do they feel? Naturally, you would think if you have a shorter duration, you might be able to justify the complete responses, and maybe the quality of life will be better after induction, which is why I think the Demeter trial would be a very good complementary trial to help us address the question of induction and then just maintenance therapy. The Demeter, however, is not going to answer the question about the CDK4/6 for the triple positive patients. So I guess we need a Demeter 2.0 to answer that question for triple positive. But I want to keep an eye on what the Destiny 09 shows with respect to complete response rates with continuing it for a longer time. What does the side effect profile, the pneumonitis rates, the patient outcomes look like? I want to see if there is a difference in ER negative and ER positive patients within Destiny 09. And maybe we might land up having a strategy where for ER positive patients, we might land up doing the Patina-like regimen. For ER negative, there's a very good chance we might consider a Demeter-like approach based on the complementary results from that. Or if the efficacy and the complete response rates are beyond believable, we might be tempted to continue in the first line. So I think we have to just wait and watch a little longer, and hopefully we'll have the results this year.
Excellent overview. Let's move now to HER2-Low and HER2-Ultralow. So we know perfectly that trastuzumab deruxtecan is actually the standard of care for patients with HR-positive HER2-Low, defined as immunohistochemical 1+ and 2+ and FISH non-amplified, after one line of chemotherapy. But we have also another ADC approved, that is sacituzumab govitecan. In later lines of treatment, sacituzumab is also approved for triple-negative disease. And we are waiting also for the approval, at least by FDA and EMA, of datopotamab deruxtecan, that is another anti-TROP2 that in the TROPION-Breast01 clearly demonstrated the benefit in terms of median progression-free survival. The next question was to evaluate activity of trastuzumab deruxtecan in early line of therapy in the metastatic setting. So that's why we designed the Destiny Breast 06 prospective randomized trial evaluating activity of trastuzumab deruxtecan without any previous line of chemotherapy in HER2-low disease, immunohistochemical 1 plus and 2 plus, and FISH non-amplified. But since we demonstrated activity already in the Destiny 4, the next question was also to evaluate activity of T-DXd in those patients that are according to ASCO-CAP HER2-0, but we know that in their HER2-0, we have patients expressing on a tumor any staining between 0 and 10%. And we defined this patient population as HER2-Ultralow. So Destiny 6 assessed activity of trastuzumab deruxtecan in HER2-low and HER2-Ultralow population without a previous exposure to chemotherapy. And I believe this is really important. So why it's so important? Because we know that the expression of HER2 is a spectrum of disease where you have staining for HER2 from 0 to 3 plus, with the different expression, of course, across the HR-positive and the HR-negative population. So let's move now to evaluate the Destiny Breast 04. That was the first clinical trial to evaluate the activity of trastuzumab deruxtecan in the patient population with HER2-low disease. This was a prospective randomized trial for patients with HR-positive and HR-negative disease who received one or two previous line of chemotherapy. Patients have been randomized 2-to-1 to receive trastuzumab deruxtecan versus chemotherapy of investigator choice. The primary endpoint was a median progression-free survival by blinded independent central review in the HR-positive population, and the key secondary endpoint included PFS by blinded independent central review in all patients and overall survival in HR-positive population. The trial, also with the longer follow-up, demonstrated a clear benefit in median PFS, with an improvement of median PFS in HR-positive disease from 4.2 months to 9.6 months, and an overall survival benefit from 17 months in the chemotherapy arm to 23.9 months in the HR-positive disease in trastuzumab deruxtecan arm. We have to remind there was a cluster of patients, 56 patients with HR-negative disease. They also derived a dramatic benefit from trastuzumab deruxtecan. Median PFS was improved from 2.9 months to 8.5 months, and median overall survival from 8.3 months to 18.2 months. Next step was to evaluate activity of trastuzumab deruxtecan without any previous line of chemotherapy. In the Destiny 6, we randomized more than 863 patients to trastuzumab deruxtecan versus chemotherapy of investigator choice. The primary endpoint was median PFS by blinded independent central review in HER2-low population. Key secondary endpoint included PFS in intent to treat, overall survival in HER2-low, and overall survival in intent to treat population. We had 153 patients with HER2-Ultralow disease, defined, as I said before, as any staining between 0 and 10%. What's about the activity? Trastuzumab deruxtecan in a patient population progressing to CDK4/6 inhibitors improved the median progression-free survival from 8.1 months to 13.2 months, with an hazard ratio of 0.62. In the analysis of their HER2-Ultralow population, we had a very similar result, with an improvement of median progression-free survival from 4.9 months in the chemotherapy arm to 13.2 months in the trastuzumab deruxtecan arm. So in conclusion, the use of trastuzumab deruxtecan in HER2-low and HER2-Ultralow population derived the benefit from trastuzumab deruxtecan when compared to the chemotherapy arm. During San Antonio this year, we had specific subgroup analysis in this patient population. The first analysis was to investigate the benefit of trastuzumab deruxtecan in patients with a different response to endocrine therapy plus CDK4/6 inhibitors. So, I mean patients with rapid progression, patients with later progression. Then we assessed the efficacy of subsequent therapies post-progression on TDX. And finally, what's about tumor burden? Less than 3 metastatic site of disease or more than 3 metastatic site of disease. The first observation is that in patients with a clear endocrine primary resistance, there was a huge and dramatic benefit from trastuzumab deruxtecan. So in those patients with the rapid progressive disease within 6 months of first-line CDK4/6 inhibitors, trastuzumab deruxtecan improved the median progression-free survival from 6 months to 14 months. Of course, we had a similar benefit also in 6 to 12 months and more than 12 months, but it's quite important to understand that in the hard-to-treat population, in the really refractory population to CDK4/6 inhibitors, benefit of chemotherapy is very limited, 6 months, and benefit of trastuzumab deruxtecan is really huge. Don't forget that overall response rate and duration of response by time to progression on first-line endocrine therapy plus CDK4/6 inhibitors was very similar across the subgroup. In any case, a response rate of more than 60% and the median duration of response ranging from 11 months to 15 months. Finally, we evaluated median PFS too, and also here we discovered that the use of trastuzumab deruxtecan favored this patient population, both in intent to treat and also in the subgroup of the patient population. Finally, we evaluated the activity of TDX in patients with less than 3 metastatic sites at the baseline or more than 3 metastatic sites of the baseline, confirming that the benefit of trastuzumab deruxtecan was observed regardless of the tumor burden. Don't forget that the future will be, of course, to combine trastuzumab deruxtecan also with immunocheckpoint inhibitors in the triple-negative population. And we have also some data of TDX in combination with capecitabine and capivasertib. But beyond trastuzumab deruxtecan, new data are available also for targeting TROP2. And now I would like to invite Professor Javeri to summarize the data on sacituzumab and datopotamab deruxtecan in HER2-positive disease.
Thank you, Dr. Corigliano, for this excellent overview. We've really come a long way now that we can offer these antibody-drug conjugates, specifically trastuzumab deruxtecan, to majority of our breast cancer patients, and we eagerly await what the regulatory agencies will do with the ultra-low, such that nearly 90% of our patient population might then be eligible to getting this antibody-drug conjugate. Let's also review the role of TROP2-directed antibody-drug conjugates in clinic for our patients and see where we have come there. I think the very first TROP2 antibody-drug conjugate that was approved for HR-positive, HER2-negative was sacituzumab govitecan based on the results from the TROPiCS-02 trial. Now, this trial really mandated patients to get a CDK4/6 inhibitor. This also demanded that patients enroll if they've had received at least 2 lines of chemotherapy, no more than 4 lines of chemotherapy. And as we know that about 98% of these patients had received a CDK4/6 inhibitor and a median of 3 prior lines of therapy. And despite this heavily pretreated patient population, we did see an improvement in both PFS and OS with sacituzumab govitecan, and that led to its approval and our utility of this drug for our patients in clinic. Specifically for PFS, which was the primary endpoint and shown on your left, there was a modest improvement from 4 months to 5.5 months. But if you look at the landmark analyses, nearly 3 times the patients were progression-free at the 12-month landmark point compared to the standard of care chemotherapy arm. And then when we looked at the overall survival as shown on the right, the delta of benefit was nearly 3.2 months in the sacituzumab arm compared to the physician choice chemotherapy arm. Now, when we looked at efficacy for this TROP2 ADC by HER2 status, now certainly this is a TROP2 agent. We don't even require testing for TROP2 in clinic to offer these therapies, as majority of our patients are thought to be TROP2 overexpressing. However, given that the field had evolved when we had antibody drug conjugates for HER2-low and IHC0 tumors, we did this analysis and looked at the efficacy of sacituzumab. And needless to say, it didn't matter whether it was an IHC0 tumor or a HER2-low tumor. Compared to physician choice chemotherapy, sacituzumab performed better in both of these groups. Looking at another antibody drug conjugate against TROP2, for which we now have data from the phase 3 Tropion Breast 01 trial, it is datopotamab deruxtecan. Again, the payload is similar to trastuzumab deruxtecan. It's a deruxtecan payload. The antibody is against the TROP2 antigen. Unlike sacituzumab, which is delivered day 1 and day 8 of a 3-week cycle, this is administered every 3 weeks. And here, we had tested this drug after patients had had at least 1 line of chemotherapy, no more than 2 lines of chemotherapy, and we saw that there was an improvement from 4.9 months to 6.9 months, and the hazard ratio here was 0.63. The trial had dual primary endpoints, both PFS and OS. These are the PFS results. We had seen a press release that the overall survival benefit was not met. We are awaiting the agency's decision about what will happen with this drug. However, it was recently released that it has been approved in Japan for patients with HR-positive disease based on these results. Similar to what we have done in HR-positive disease, sacituzumab govitecan is also approved in triple-negative breast cancer. In fact, this drug was first approved in triple-negative breast cancer. These were data from the phase 3 ASCENT trial that really changed the standard of care for metastatic triple-negative breast cancer patients. On the left are the results from the PFS from this study, and we see an improvement from 1.7 months in the control arm to 4.8 months. Very humbling, very sobering to see that our control arm did only 1.7 months on this study. And with sacituzumab, there was an improvement to nearly 5 months. Similarly, overall survival benefit, there was near doubling of overall survival benefit from 6.9 to 11.8 months. And this has really become a standard of care for our patients with metastatic breast cancer with at least 1 line of chemotherapy in the metastatic setting. Again, we tried to do the analyses by HER2 status, even in the ASCENT study, and even in this patient population, regardless of whether they were IHC0 or IHC HER2-low, the benefit was maintained with sacituzumab compared to physician choice chemotherapy, which again is not a surprise. There is a third TROP2-directed antibody drug conjugate. So certainly we have the embarrassment of the riches. We have multiple topoisomerase 1 inhibitor, but 3 TROP2 ADCs to be specific for our patients. These are data from the OptiTROP Breast 01 trial for sacituzumab tirimotecan. This is, again, a TROP2-based antibody drug conjugate. And here, again, we did see a statistically significant improvement in PFS as shown on your left by blinded independent central review. And certainly a benefit was also seen with the interim overall survival in the right as well. And there is a phase 3 trial ongoing in the first-line metastatic hormone receptor positive setting. Similarly, we also have the ASCENT-07 trial that is currently ongoing with sacituzumab govitecan, which actually just completed its accrual, and we are now eagerly awaiting results. This is again for patients who've had endocrine-based regimen therapies, but when it's time to switch over to chemo, it's the first chemotherapy option that could be considered. So randomization as first sacituzumab versus physician choice therapy in that study as well. Now, this was the Tropion pan-tumor 01 study. And the reason I wanted to show this data was that there was an interesting finding from the small cohort of patients when we thought about metastatic triple-negative breast cancer tumors and what activity we've seen with datopotamab deruxtecan for metastatic triple-negative breast cancer here. And what we had learned was that when we think about all patients with metastatic triple-negative breast cancer cohort treated on this pan-tumor 01 trial, certainly the median PFS was about 4.4 months. However, if we were to look at the topo-naive patients, this was 7.3 months. which also reminds us that for patients who had either received prior T-DXd or prior sacituzumab and then received Dato-DXd, there was still some activity seen, at least in the small cohort of patients, which was a very interesting signal, something that might be relevant for us now to look at from real-world data sets, and we have been, to think about how do we utilize these agents in sequence and what should we be expecting when we do that. So we now await results from the TROPION-Breast02 trial in the metastatic triple-negative breast cancer, the definitive phase 3 trial, to see how datopotamab deruxtecan will fare for those patients in that study. At this point, maybe we can move on to some case-based discussions. I'll have Dr. Corigliano maybe present the first case.
Yes, absolutely. And this will be an opportunity, of course, to do an interactive discussion because personally, I believe the clinical cases are really challenging. So let's go to the first clinical case. That is an HER2-low clinical case. And this was a patient with 49 years old with a previous melanoma diagnosis. And in February 2023, she was diagnosed with a 4.5 centimeter right breast lump with axillary node positive. So she did a biopsy, and this was a triple negative early breast cancer. A germinal BRCA testing was performed, and she was BRCA1 and BRCA2 wild type. So since this was a stage 3 early triple negative breast cancer, we started pembrolizumab, carboplatin, paclitaxel, followed by epirubicin and cyclophosphamide according to the KEYNOTE-522 regimen. In October 2023, she performed a right mastectomy and an axillary dissection. And unfortunately, there was residual disease with an YPT1C 15 millimeters, YPN1A 2 out of 18 lymph node, and zero disease. We started radiation therapy concurrently with pembrolizumab. In Europe, we cannot add, finally, capecitabine to these patients. But during adjuvant pembrolizumab, she had a progressing disease with supraclavicular and mediastinal node progressive disease. We performed a biopsy, and on the recurrent disease, we had ER negative, PR negative, but HER2-low disease. So my question for you, Komal, is what you are going to do now? You start directly with sacituzumab, or you can give trastuzumab deruxtecan. Consider that in Europe, we cannot give sacituzumab govitecan according to the date of the ancient trial in the first-line setting. And if we have to select an evidence-based approach, we cannot give sacituzumab frontline. So which is your opinion on this clinical case?
No, I think it's an excellent point. I think along the same lines, I feel like if we were purely to look at the data, I'm not sure we can apply even the T-DXd data here, despite the DESTINY-Breast04 study showing the activity from an exploratory group analysis of 58 patients, which I really think it's an excellent drug. I certainly do think that that's an active drug. But again, the approval in the triple-negative breast cancer patients or the HR-negative HER2-low patients is based on that 58-patient exploratory analysis and really not focused on the first-line setting as well, or not immediately post, KEYNOTE-522-based regimen as well. I would be tempted to try and get approval for sacituzumab. And to be honest, I have done that successfully in the United States. So that might be just the differences in our practice patterns and our countries and what we can do for our patients in our countries. But while we don't have the data from the ASCEND study specifically in the frontline setting, because of how we are now utilizing the KEYNOTE-522 regimen and what's happening with those patients, I would try and justify or appeal to try and get approval for sacituzumab. And if I can successfully get that, I would try that. Certainly, if I could not get that, I would try trastuzumab deruxtecan, given that we have the data from the DESTINY-Breast04 as well. So I feel either or would be appropriate. I have been following the ASCEND data just because it's a larger, robust data set. And remember when I was showing you that analysis from the tropion pan-tumor-01 study with datopotamab, I always find that very interesting that despite prior TOP1 inhibitor therapy, there was still activity with deruxtecan, datopotamab deruxtecan for those patients, kind of telling me maybe, deruxtecan is more potent and maybe I'll be able to still get some activity at the back end. And I should think about sacituzumab based on the ASCEND study and also maybe with subpotency at the back end. These patients are going to need these drugs one way or another.
Yes, I completely agree with you. We have more evidence from the Asian trial. Unfortunately, in Europe, we don't have a lab for the first line setting. And that's why finally, according to the reassessment of their HER2 status, what we did is to give trastuzumab deruxtecan. What if a patient will progress to T-DXd? In that case, of course, I will give for sure sacituzumab govitecan and vice versa, because if you give first sacituzumab, I would give T-DXd after. So she received the trastuzumab deruxtecan, and you can see over here, this was the baseline assessment. And after really a few months, patient is still on treatment with trastuzumab deruxtecan. She achieved an excellent response on the CT scan of October 2024. The second clinical case is a little bit more challenging. This is a 75-year-old woman. And of course, we only hypertension as a comorbidities. In December 12, 2018, she did a mastectomy and axillary node dissection for a ductal infiltrating carcinoma, poorly differentiated, the ER-positive, PR-positive, HER2-0, according to ASCO-CAP. So the stage was a PT2, PN1, and so she received chemotherapy, standard chemotherapy, but during abemaciclib plus fulvestrant in the monarchy trial, she experienced a progressive disease on bone and pleural effusion. So, of course, what we did a first-line therapy with abema and fulvestrant because she progressed during letrozole, adjuvant letrozole. And then after 2 years, she had the progressive disease on the liver. So what we did is a liver biopsy. It was ER-positive, PR-negative, HER2-0 again, but there was a PI3 kinase mutation. So we included her in a clinical trial with the PI3 kinase alpha selective inhibitor that was Relay 2608, continuing fulvestrant. Unfortunately, she had a new progressive disease, and so we performed the liver biopsy, and here in this scenario, there was an HER2-Ultralow disease because HER2 was more than 0 and less than 10%. And that's why we started the trastuzumab deruxtecan, achieving a partial response. So just I would like to remind to you that in the DESTINY-6, we performed the central analysis, and we discovered that when you have an HER2-0 on the local testing, 40% of them are HER2-Ultralow, and 24% of them are HER2-low. So it's really essential to reassess HER2 to perform multiple biopsy, because sometimes you may have an HER2-low disease. Do you have any comment on this?
Yeah, no, I think it's such an interesting analysis. I think it's also a very sober realization of how complicated this has become, given that the way we designed IHC was just to identify HER2 3+ tumors from HER2 negative tumors so we could offer anti-HER2 therapies. And now we have to ask our pathologists to make sure that they find the smallest speck of HER2 expression, because we want to not miss an opportunity to offer T-DXd to these patients. And so it becomes so important, but also challenging for our pathologists to be able to really tease out and stay concordant between their findings of IHC 0 and within IHC 0 ultra low or even HER2 low tumors, I think. So yeah, I think this is great. I think it reminds us that maybe we need a better refinement of our IHC technologies or a better way of testing HER2 so we don't run into these issues, and we can really offer these therapies to all the patients with some HER2 expression, or sometimes questioning the paradigm, do we need to check it for all patients? We don't check it for TROP2. Should we be checking it for HER2, or just teasing out patients who should just not be a candidate for HER2 and otherwise offering T-DXd to all. So yeah, certainly a very interesting case.
And then we move to the last case. That should be your case.
So this is case number 3. This is a 68-year-old woman who presented to clinic for a newly diagnosed metastatic breast cancer. And really what she presented was she was diagnosed with an 1.3 centimeter node negative invasive cancer, which was ER positive, PR positive, and HER2 positive. This was 4 years ago. She underwent breast conserving surgery and then she was lost to follow up. She did not receive any radiation. She did not receive any systemic therapy. She developed abdominal fullness, had some right upper quadrant pain, and some significant fatigue, which brought her to the emergency room where imaging was performed and an 18 centimeter liver with multiple solid metastases was found. The liver enzymes were also abnormal, 3 times the upper limit of normal, but function was otherwise normal, meaning the bilirubin was otherwise normal. Biopsy did confirm that this was truly, again, the triple positive breast cancer. So ER, PR, HER2 positive. This was really high grade. She did undergo staging brain scan at that time as well. And that was a single 2 centimeter brain metastases. So maybe, Giuseppe, I'll ask you here, if such a patient came to you with now de novo metastatic breast cancer with no prior adjuvant radiation, no prior adjuvant chemotherapy, so really naive, but now with extensive liver metastases, liver function abnormalities, and a 2 centimeter brain met, which seems like she's not symptomatic from the brain met, it's more from her disease, what would you do first?
My first line treatment is a dual blockade with pertuzumab, trastuzumab, and taxane. I would also consider eventually a stereotactic radiation therapy on the single brain mets, because since there is also extensive liver disease, I would not consider a surgery on the single brain mets.
I completely agree with you. And that's exactly what she got. She was treated with THP. After 2 cycles, she was symptomatically much better. After 4 cycles, there was a 70% reduction in her tumor burden. And after 6 cycles, she had a complete response in her liver, which was quite dramatic. She developed moderate neuropathy as well as edema related to her taxane. The taxane with this maximal response and complete response in the liver was dropped, as we did in the Cleopatra trial. She continued on the HP-based therapy, as we do in practice because of her triple positive cancer. An aromatase inhibitor was added to her HP-based therapy. And 20 months after that, she now has progression in the liver with a new 1 centimeter metastases as well as new lung metastases. So now she has, again, systemic disease burden. She did get SRS to the brain or to her brain metastases. The question is, what would you now recommend as second line treatment option? And if the patient had no baseline brain metastases but developed them upon progression at this time point, would that make a difference in your treatment choice?
But according to the data of the Destiny Breast 03, here you can consider for sure trastuzumab deruxtecan in the second line. Also, if you have another brain mets, because don't forget that in the Destiny 3 there were many patients with baseline brain mets, and some of them had also a response on the brain without any radiotherapy. They were not eligible patients with active brain mets, but they were eligible patients with pre-treated brain mets eventually, and it had been enrolled in the trial following progression in other site in the Destiny Breast 03. So my treatment option here is trastuzumab deruxtecan.
I completely agree with you as well. And I completely agree with you about your reminder about the brain mets patient population. This patient did get trastuzumab deruxtecan as the treatment of choice. And I would agree, even with a new brain lesion, with systemic disease and brain lesion, I think very appropriate to give her T-DXd. From Destiny Breast 12, we learned that even with active brain mets, we can now justify T-DXd. So I feel like given the totality of evidence for T-DXd and the robustness of the data set, I would be very tempted to offer this patient T-DXd regardless of where the progression was. So any key takeaway messages for our listeners, for our viewers?
For HER2-low disease, of course, I personally believe that trastuzumab deruxtecan data, both in the Destiny 4 and in the Destiny 6, are practice changing. T-DXd is more effective than chemotherapy, both in HER2-low and HER2-Ultralow disease. And of course, we are waiting also for the approval of datopotamab deruxtecan and the data of the Asian-7 for sacituzumab govitecan. So exciting new data in HR-positive, HER2-low disease.
I completely agree. And I can't wait to see all the initiatives of bringing T-DXd and sacituzumab and maybe even datopotamab in early stage tumors for triple negative, for HER2 positive, for both of those subtypes, and how will that impact as well. So very exciting time to use these novel antibody drug conjugates for our patient that has made a dramatic difference.
And from PeerView, from Giuseppe Curigliano and Dr. Komar Javeri, see you in the next educational activity.
Thank you all.
Thank you for listening. Remember to download the slides and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This activity is supported by independent educational grants from AstraZeneca and Daiichi Sankyo Incorporated. To access all materials for this activity, visit peerview.com/TQX860.